So we're delighted to have Keith Van Haren here next, who's not only a neuroimmunologist and been doing such seminal work on cerebral ALD models and been so persistent in coming out with the first animal model of cerebral disease, but also running a leukodystrophy clinic and beyond the science and being a caring physician, he's also somebody who understands how to talk to other people and has been a big support to the patient community. And now I'm so delighted that he's taken on the task of becoming our president. So a big shout out to him.
Okay, thanks guys. I'm going to give an overview. So I mentioned that the natural history studies from newborn screening are just kind of beginning to come out. We have, I think, the centers have gathered enough experience to start putting things out. I'm going to follow up on some of the work that others have put out. I had a wonderful visiting scholar in our lab, Cecilia Wiedebeck, who would have been here today if she weren't expecting a baby today. So it's her first. We're very excited for her. So she and I have been in conversation for years about different projects, and she finally actually took leave from her position or did an exchange fellowship from her position at Copenhagen University Hospital, where she works as a metabolic neurologist and geneticist. It came to spend 6 months at our center and did a fantastic job pulling together initially our natural history cohort, finding it so compelling and interesting that she expanded it to 5 other centers to put together really compelling stories. So the work I'm showing you is really Cecilia's wonderful work that is, we're just trying to dot the last few I's to get it into submission here. Sorry to go back. I don't have any relevant disclosures for this talk. I do speak with and consult with companies and carry grants from several places, but nothing that's quite relevant here. Let's see, do I have our, okay, coming up next slide here. These are our collaborators. We have Utah, MGH, Kennedy Krieger, Minnesota, CHOP all contributed cases. Where are others who have great natural history databases we will get to in time. We're eager to expand this. I want to give special thanks to Joe Orsini, Lisa Seeger, and Miranda, who is here today, for their work in helping to sort of continue to push this forward and bring these groups together to maintain this conversation. To Dr. Lund, who is unrelated to Troy so far as we know, but is Cecilia's mentor at Copenhagen University, and Stefan, who's been maintaining this database that we all find so useful for so many years. Okay, we've had several funders over the years for various projects, all kind of in this domain, and I want to give a shout out to them here. There's a wonderful family that does a hike every year to support our work. There's the Yoler Lanai family, and who have started a gift in their son's honor, who passed away. They are a family affected by LD, but their son passed away in a tragic outdoor accident, and he was a dear person and friend to me. His brother Alex is here with us and is pursuing science in this space. Max worked in my lab, and we do lots of things in Max's memory. The Lucas Project is also wonderful, as the Adler family that has sponsored work with us in the years past. And Rivederci ALD and the Brain Foundation, who have founded a new clinical fellowship, which has sponsored separate work. The Cure ALD Foundation is new. It's run by the Terry and Alex Wiener family, and we're excited to have them as part of our community here for, I think, their first visit, and some NIH funding as well. So, okay, onward. So this is, I think this is the best contemporary natural history study we have. This is done by Florian and Mark at MGH, and the AMC. This outlined a natural history of 159 patients who came to us mostly in traditional fashion, meaning they all came from symptomatic families for the most part. There were a few who maybe were identified by newborn screening, but this was in the very early days. And this was, I think, has really kind of underlined our modern understanding of kind of the pathogenic variant, and I use those technical terms here as lightly as I can, but traditional ALD. And they profiled the experience in their clinics. They found and really solidified the way we think about the natural history of ALD now. And this was building on a lot of really nice prior work by Hugo Moser and others defining this, but I consider this kind of the gold standard for now. What they found is that about, for adrenal insufficiency, about half of boys had adrenal insufficiency by age 10. And that rate of adrenal insufficiency, or developing decreased once you got past the age of 10. And something similar for cerebral ALD. The absolute value here was 30%. They did find differences in rates between centers. This could be referral bias and other things we don't know. I'll note here importantly, this was pre-C26-LPC era. And so this was a moment where we couldn't find associations with very long chain fatty acids in clinical disease. And that was because we didn't have the biomarkers we do now. We were using just the free very long chain fatty acids. Without getting too technical on everybody here, there were some seminal papers that came out in 2006, 2009, and then 2020. This last one is from Yorick and Stefan, where they identified C26-LPC through some really dedicated, detailed work of many, many lipids, finding that it seemed to be the most sensitive and specific for ALD diagnosis. And this is a comparison chart here. You can see, I'll point this out here, that whereas there is a lot of overlap between kind of like controls and affected people or some amount here, there is much less here in this when you use this. So this is the older lipid model, C26-LPC, and this is a ratio. But C26 alone. But when you use C26-LPC, you get better distinction between the conditions. This was a really important kind of landmark. We didn't, I think, probably realize quite how useful it was going to be prognostically, but it was an important diagnostic thing. It is now used for newborn screening. Fast forward a short time, Yorick and Stefan also began to, as you've seen already, find that this marker was not only good at diagnosis, it was useful for prognosis. So it now is a marker that does predict, again, it's a probabilistic prediction. It is not a black or white prediction. It's probabilistic, but is useful for predicting who develops symptoms. This is from Yorick's and Stefan's beautiful paper detailing this work, published last year. Troy Lund and the Minnesota newborn screening teams published this very nice paper on their Minnesota cohort. I believe this is all the patients in Minnesota, 33 boys identified in this window with a median follow-up of about 5 years. And they reaffirmed that not just in adults, but in newborns, C26-LPC levels are useful for predicting prognosis. And this is now, so this is the workflow for newborn screening. Here we begin with C26-LPC screening. We proceed to eventually ABCD1 gene sequencing, and then we wind up lumping all of the non-benign variants into a positive result. Everyone with this positive result, variants of uncertain significance included, wind up under, for right now, the same monitoring protocol. And I don't need to tell the families in the room this, but this monitoring protocol is both kind of logistically, but particularly psychologically quite taxing. And it is very good at what it does in catching early pre-symptomatic adrenal insufficiency or cerebral disease, it is hard in terms of, in other ways on families, but it is achieving its desired effect medically. It is burdensome psychologically, financially, and so on. One of the big fallouts, as we've touched on here, are the variants of uncertain significance constitute many of the patients and families identified through screening. And you can see, this is what Stefan refers to as the gray zone. In this, when we have the C26 or cutoff on the left bar there, you can see there's this area in the middle where there are quite a few variants that kind of fall in this in-between zone, and these are often where we see these variants of uncertain significance. And so your detection rate for these variants of uncertain significance will rise and fall depending on where you set your threshold. So to get to the point of the study that Cecilia and the rest of us have undertaken here, our question was essentially this: what is the risk of ALD symptoms for boys with the VUS? And anyone would have told you the risk is lower, but this was really our attempt to say that more definitively to try and quantify this. These are the 6 centers that contributed. In green are all the states that currently screen. You can see the amazing progress that the ALD Alliance and many, I should say many other groups as well, but the ALD Alliance has really led this effort to try and roll newborn screening out across the U.S. And this was Elisa Seeger and Miranda McCullough making this effort. So our patients in this particular study came from 19 states. These are the 6 centers. You can see that the variants of uncertain significance here are about half of the group. And then these pathogenic variants are those that were quite certain cause disease. In other words, they've been previously associated with ALD symptoms. This likely pathogenic variant is something even a little more nebulous in some ways than the VUSs, in that they have been possibly associated with disease but appear to be likely to cause disease. These seem, at least through various computational models, less likely to cause disease. That is how they're currently triaged. Our median follow-up times were all about 4 years across all sites and across all variants. So both variants of uncertain significance and pathogenic variants had similar follow-ups. C26 levels, I'll touch base on this a little bit further again, but our rates of adrenal insufficiency, in total we had 54 of 200 children developed adrenal insufficiency in the period of observation. This is just in the time we followed them. 16 of 200 developed cerebral disease, and you can see that these breakdowns look quite different across pathogenic, likely pathogenic, and variants of uncertain significance here. So in each case, pathogenic has the highest penetrance and lower as you go down. Again, this is all expected. This was our attempt to sort of try and quantify this and move it forward a bit further. So what else did we see? We saw that, yes, these C26-LPC levels did split up by variant class. We also saw, again, that the higher the C26-LPC levels, the higher these orange dots here. If it's orange, circle, it's adrenal insufficiency. If it's a triangle, an orange triangle, it means they have both adrenal insufficiency and cerebral ALD. Here we have, patient with both. We have one patient with really just cerebral ALD behind that patient. These are their levels. You can see that in each group, we have patients who develop symptoms, including the variants of uncertain significance. You might rightly ask, why are these variants of uncertain significance still listed in this way? What we did, and for the purpose of this study, was we used the original classification to sort of the clinician's point of view, or the family's point of view. If you knew you had this at one time, what did it mean for you later on? These are likely to be reclassified in the future. But for the purpose of this study, they were as shown. Our lowest C26-LPC for somebody who develops cerebral ALD was at this level here about 0.5. And our lowest level of C26-LPC for adrenal insufficiency was at this level. Now, Stefan and others have, when we've currently working on kind of peer reviewing the manuscript within the co-authors, and we send it to a journal for further peer review. In reviewing it with co-authors, people say, well, why are we, how do we classify adrenal insufficiency? What if the patient only needs stress dose steroids? Do we still count that as adrenal insufficiency? Our team and within consultation with our endocrinologist said, yes, this is how we want to classify it. It is, the term of art, I believe, is partial adrenal insufficiency, meaning your adrenal glands need some support under stress. That is an important medical change that warrants a special classification. It does not, what we do not capture here is what happens. There is a group here of people with partial adrenal insufficiency that may not develop further. They may, I have seen one case where the partial adrenal insufficiency resolved to something that was no longer, permanently insufficient. We're following them for continuously, so that may change again over time. But there is some nuance here. So cerebral ALD we kind of think of as a yes or a no. Adrenal insufficiency, I do think there's a little more nuance there. So I want to include that caveat. We were very broad in our categorization here. So this adrenal insufficiency, these may include some milder cases, is my point. These are called survival curves, and they originated actually, I believe, in the cancer space as literal survival curves in terms of who survives. And the way you read them is everyone starts here where 100% have the condition of what this is really is, what we mean by survival here is survival without adrenal insufficiency, mean time without adrenal insufficiency. And so what this means over time is that here 100% had no adrenal insufficiency, and as you move over time, you see this number follow. So here at about, this time point, about 25% had developed adrenal insufficiency, but 75% remained without, and so on. To right about here, this is just beyond 4 years, where at this point, about 50% of those with pathogenic mutations had developed adrenal insufficiency by around 4 or 5 years or so. This red line is, it's not labeled up here, my apologies. This is the pathogenic variants and likely pathogenic variants. They're lumped together. These are the variants of uncertain significance. So you can see that over time, even following for several years, the risk to people with variants of uncertain significance appears lower at this time point. So the interpretation here is boys with likely pathogenic variants had higher odds of developing adrenal insufficiency compared with those with VUSs. We have an odds ratio here. Odds ratios are hard to conceptualize even for clinicians. What I think the takeaway here is this is a big odds ratio, meaning the difference is very substantial. So those people with variants of uncertain significance, to invert this, have substantially lower risk of adrenal insufficiency. But in the classifications that were assigned at birth, even those with VUSs, the risk was not zero. And that's an important point to keep in mind. We'll get into the nuance, I hope, as we move along. Same thing applies here. Again, these are the pathogenic variants. These are the VUSs. What this indicates here is that there was a boy with a VUS who developed cerebral ALD kind of quite a ways out here. And so this does change a little bit of the curve. The takeaway here is that the incidence was low enough that it actually made it hard to get a statistical signal distinguishing these two bars. If we had many more patients, we would probably see a difference between these two. As it stands right here, statistically speaking, on a mathematical level, we say these are approximately equivalent risk. That most of us would say is just an artifact of small numbers. Okay. I would say it may be heartening to know that at least in the window of time that we followed, patients, even those with pathogenic variants, had lower rates than, had fairly low rates, keeping in mind that we only followed for a median of 4 years. This is perhaps a complicated map. This is what we tried to show with this figure. Each dot on here represents a patient or a newborn screen. The dot is color-coded at the last clinically relevant outcome. So if it is colored orange or purple, it means that is the age at which that symptom presented. And if it remains blue, it means that this is their last age of follow-up. What we were trying to visualize here was whether those with higher levels of C26-LPC actually presented earlier in life than those with lower levels. And I don't think we quite got to a statistical measure of this, but that is what we can sort of see here. In other words, all of the high levels tended to sort of manifest earlier. There are only a few out at this time frame, further out in life, that had not yet manifested symptoms and were above like a level of 1, say. And typically those with lower levels tended to get to a later age without developing symptoms. Now, this is not a lifelong map. This child, this is in months here, just to confuse everybody. But to divide this by 12, you'll get the approximate number of years. So let's say, this is like, somewhere around 7, 8 years. And these kids are all, of this age without symptoms, okay? Without either adrenal or cerebral symptoms. And, and this child here was very young when we stopped the clock, and so we don't know. Same with this child here. It has a high level, but that was the last clinical follow-up for that child. What we did get to here is basically this number is for each 0.1 unit increase in C26-LPC. This conferred, again, the odds ratios and hazard ratios are a little complicated, but I would think of this as each 0.1 increase in terms of micromoles per liter led to a moderate increase in risk for every dot, every 0.1 level increase. This was one of the goals we set out to do, was trying to quantify this and give us a sliding scale. This number is not frozen, it's not written in stone. It is an artifact of where we are right now. It will probably change, but this is our first measure of this number. And so this gives us at least a ballpark for how to think about these levels. And for those in thinking about planning clinical trials, developing therapies, whether or not lowering this by the same amount would reduce this, that is what we, in a perfect world, would say, okay, well, if this much of an increase gives you risk of disease, this much of a decrease will give you the converse. In a perfect world, we would hope that is true. But this just gives us some sense of things, of how to quantify these measures, okay? This was interesting, and this came out of one of the analyses. This wasn't exactly what we thought we would see, but what we're showing here is for every genetic variant where we had at least 2 measures, we mapped the C26-LPC level. And what we can see here is that these cluster quite well. So for every person with the same genetic variant, their C26-LPC levels were quite similar. This is part of that change in how we think about genes and the genetic change and the biochemical change and the risk of symptoms. But I would say this is that intermediate step between your genotype helping to predict your symptoms in the future. It's not that. I'm not saying that literally right here, but this is that in-between step that we're seeing here. We're seeing pretty good correlation across, and this is even across state labs. I was a little surprised by how relatively well this worked. All state labs use different machines, different equipment, different people, and yet the measures looked pretty consistent across the state labs. So one state lab measuring somebody with this genetic sequence would seem to get a similar result to other state labs measuring somebody with that genetic sequence. That's a good thing. That means we can generalize a little bit. Yeah. So, okay. The big limitation here is this is not lifelong risk. This is risk for the period of observation here. So half of the kids were under 4, half of the kids were over 4. A quarter of the kids, meaning 50, this is 200 kids, so a quarter is 50. So 50 were over age 7, and I think the oldest was maybe 12. So we don't have a lot of children who were in that older age group yet. And we did not expand this to adults at this point, adult male relatives, which would have really changed. If we did, it would change some of these curves. But this is where we are now. And this is, we think, we're happy with what we were able to learn from what we have. There's more data in here for those who are interested in diving deeper. But we did find a substantial difference in genotype classification and prognosis. The rates of cerebral ALD were quite low, and the children were quite young. What we do know is that the peak risk of cerebral ALD disease occurs a little bit later than age 4. So a lot of the kids haven't reached that age. Many have, and so we can say something about it, but I think that in particular needs a little more time. And yeah, I think we are seeing some new associations, which are not particularly surprising, but it's helpful to have these as, I think, rules of thumb for us to work from. So we think this is an important milestone, but this is accumulating knowledge. And so for those of you in the audience worried about your level being one place or the other, your family's level or your child's level, this is a probabilistic risk, meaning it's, yeah, it is not it still is not black and white. It never will be black and white, but it is something that we can begin to think about more quantitatively for the purposes of trials, for the purposes of conversations with each other, for the purposes of, understanding even how to plan kind of the clinical surveillance for people who might be at very low risk. Do we need to do all of the same cumbersome things for them and so on? This is the beginning of that conversation. So, okay. Yes. Good questions.
Thank you, Keith. That was excellent. Can I just ask, though, the whole VUS thing I get worried about because I think people are talking about different things when they say VUS. Because I know I've sent labs on people that have clear cerebral disease, and it's reported back on the paper as a VUS. I'm assuming you're talking about VUS based on something, on the ABCD1 database or something. But I just think we need to be careful because if I were a parent, I would think if my paper says VUS that means I might fit into this category even if it's clearly not. Because my understanding is VUS is determined by the lab that's doing the testing when it comes to the report.
Yeah, thanks, Katie. There is a table in our paper that does compare the categorizations over time and whether they've changed since they were initially issued. For this study, we used the classification that was reported on the child's report. And I remember when I started in medicine, I was surprised at how much, at the fact that things were not black and white very much at the time. And this is one of these areas where actually what Katie is saying here is that you can get different classifications from different sources, and that's really confusing and maybe quite a bit scary. But that is still the case. The reporting lab may use different prediction models and arrive at different answers. I'll tell you what I use as sort of my gold standard is Stefan's website, because I know it's manually curated by Stefan and actually lots of people in this community. So I use that. We did reference it against that, and I think I actually meant to add that slide in here, and I did not before the talk, so my apologies. It didn't change the data too much, except to say that the patients who've developed symptoms with VUSs, some of them definitely will be reclassified, and same with likely pathogenic. So then it becomes a meaningless exercise if you say only, well, we're going to move everyone to pathogenic, and then it's all VUSs with no symptoms. So we ran as sort of the experiment of real life of what was the classification at birth. If we run this again in the future, it will look different, partly because our knowledge has changed. And that does complicate things a bit too.
But,
what were you
but
going to
don't
say?
you really
Yeah.
mean that they have borderline very long chain fatty acids? Because I mean, when we're referring people to the gray zone, at least my understanding, maybe I'm doing it wrong, which would not be shocking. But my understanding is we're sending them there if we think it's a VUS because maybe they have borderline very long chain fatty acids or they don't have any symptoms. But if we have a kid come back that has flagrant cerebral disease and it's labeled VUS, we're not going to send them. So I think maybe it means more the level. I just think we should be careful because I think when families are listening, it's confusing if your report says VUS.
We don't just use the very long chain fatty acid levels for classification, but let me let some others comment on that too. I see Stefan raising his hand, and maybe Julie want to comment. But Stefan, did you want to comment on that?
And then we'll come back.
First of all, thank you very much for, and also to Cicely, doing this. This is phenomenal. Katie, I completely understand your point. And I also do understand Keith's and the group's decision to use the initial report. But if you find something that's a VUS and the patient comes back and it's clinically affected, do call me, email me, because I immediately reclassify it in the database, which is not done in ClinVar. I don't know how the process is, I don't want to go there. So what was I going to say? Okay, you don't have to only send when it's borderline. I mean, if the genetic report says VUS, irrespective of what the biochemistry in the report says, because it's often not connected, send it in, because one of the many goals of the Gray Zone project is to give you more information regarding the VUS. Is it a VUS with a very low normal variant chain acids? Then it's likely benign. Or is it in the ALD range? Then it's likely pathogenic. It's fairly simple. So do send in anything you have a question about. Can I now have the microphone? Can I ask you a question?
Yeah, real quick though, because I'm going to kick the speaker off the stage in a minute.
I have a short question, because I talked about serum gray, about evaluating and adjusting. I mean, all these states that participate probably have different cutoffs. Is there a correlation between the number of VUSs that are found per state and the cutoff they use in their screening program? Because I think that is critical information. And you must have the data in there, and you just mentioned anybody wants to dive in the data. This would be my first question.
Yeah.
Because it's the start of adjusting cutoffs.
Yeah, we haven't looked at that, Stefan, but I would say the answer would be yes, but also volume dependent. Yeah.
We did have one more question from Maria, who's been waiting. So
it's super quick. I was just thinking about ALD throughout time. What are your thoughts on the levels of C26-LPC throughout time as ADC advances? I don't know if you've ever seen anything like that, but I was
this is the question that everyone has been asking Stefan. I think he did look at it. If I can speak real quickly for you, Stefan does have data that suggests it's very stable, and it's stable over time. The caveat here is that newborn screening levels are not, they fall by about 30% or thereabouts. That's a physiologic change over the first 3 to 6 months of life.